very good morning, respected judges and one and all. I am Dr. Harika Priyamvada, I'm here to present my paper titled Factors Predictive of Recurrence in Myelin Oligodendrocyte Glycoprotein Positive Optic Neuritis. Dr. Virender Sachdev and Dr. Sonalika are the co-authors. We have no financial disclosures. MOG optic neuritis is an antibody-mediated autoimmune disease, demyelinating disease of CNS, which consists a spectrum of optic neuritis, encephalitis, and myelitis. But optic neuritis is the most common presentation and the manifestation. It is a distinct entity from the demyelinating diseases such as multiple sclerosis optic neuritis and NMO optic neuritis. And the incidence of MOG optic neuritis is more in Asian populations according to Arvind study. Being acute unilateral or bilateral optic neuritis with papillitis presentation, involvement of long segment of optic nerve, being steroid responsive, recurrent episodes of optic neuritis are hallmark of MOG optic neuritis. Recurrences can occur in about 1/3 of patients with MOG optic neuritis. However, there is a limited prior literature on these aspects. Hence, we aim to identify the factors predictive of recurrences in MOG-associated optic neuritis. We use the following materials and methods. Ours is a retrospective observational study comparing recurrent and non-recurrent cases of MOG optic neuritis done at a tertiary eye care center in India, LVPI, between the period 2018 and 2023. Though some of our patients are clinically positive for MOG antibody, we only included those cases which are serologically positive for antibody, and we preferred cell-based assay method as it is gold standard. We excluded patients seronegative for MOG as well as those are positive for NMO. We included all age groups with a follow-up of at least 3 months, since we considered at minimum 3 months is required to document a recurrence. Electronic medical records of 72 patients who were seropositive for MOG antibody were reviewed, and the data was collected for the following factors: age, gender, clinical features, best corrected visual acuity, optic disc findings, constitutional symptoms like pain on eye movements, fever, vomitings, and neurological symptoms like ataxia, seizures, headache, limb weakness are also noted. MRI brain and orbits was studied for a segment of the optic nerve involved and the brain involved. HVF pattern and mean deviation and OCT, RNFL and MGCL thickness were studied. Treatment, immunosuppression, visual outcomes, number of recurrences are all studied. At presentation and subsequent follow-ups, a total of 48 patients met the study criteria, and they were divided into 2 groups, that is the recurrent and non-recurrent groups. Most of our patients presented with long segment optic nerve involvement. The statistical analysis, we spread all the data on the Excel sheet. We use Stata software, and the p-values less than 0.5 were considered as significant. These are our results. 27 patients and 21 patients respectively are included in the recurrent and the non-recurrent groups. Our patients range from the ages of 1.5 to 61 years in both the groups, but the median age in recurrent group is 37 years, whereas 23 in the non-recurrent group. Yes, the patients in the recurrent group are slightly older, but there is no significant statistical difference between them. There was no gender predilection noted. Factors like best corrected visual acuity at presentation, constitutional or neurological symptoms, papillitis, long segment involvement, or a posterior optic involvement didn't had any significant difference between the groups, but proportion of pain on eye movements was statistically significantly higher in the recurrence group compared to the non-recurrence group, and the p-value is significant, 0.04. We also found that there was statistically significant difference in the laterality, since the majority in the recurrence group had OS as the presenting eye. Let's consider it as unilateral, whereas the majority in the non-recurrence group had OU, both eyes, as the presenting eye. The other features are similar in both the groups. 59.3% patients were presented with pain, whereas 33 patients present with pain in non-recurrence group. These are the graphical representation of all the data, and this is the distribution of the values among them. Best corrected visual acuity has a very good improvement on treatment, and the p-value is significant within the groups. They usually presented with 2 logMAR and the final visual acuity is 0. That means they have a very good prognosis. When we reviewed the literature, the baseline characteristics and the features like involvement of segment of optic nerve and all, they corresponded to the relevant data and were similar to the data. And there are recurrences reported in the Arvind study. The two studies which studied the recurrent and non-recurrent group differences are the neurological studies, which showed young adults and standard first-line immunosuppression or prednisolone to be significant, and male patients with spinal cord involvement to be significant. And hence, the significance of our study is that the major strength is that it is one of the largest studies of MOG antibody disease from India. It's a comparative study and almost the first study comparing both recurrent and non-recurrent cases in MOG optic neuritis. Though the limitations are the sample size is statistically small, and it is a retrospective study. Hence, we conclude that pain on eye movements and laterality were the factors associated with increased risk of recurrence in MOG optic neuritis. Understanding the long-term relapse risk may help clinicians more informed decisions. We also extended the data and we found starting immunosuppression has reduced the risk of relapses. However, larger further prospective randomized control trials are required to validate these observations. Thank you.
Thank you. Excellent timing, exactly.